we're going to move right on to panel 4. Panel 4 returns to the research projects conducted by the 4 centers. The panel is titled Economic Security of Social Security Benefits, Beneficiaries. We'll have the same format as yesterday with 3 research presentations, Q&A. Put it in the Q&A, please. If you need live captioning, there's a CC at the bottom of your screen. The moderator for session 4 is Olivia Mitchell. Olivia Mitchell is a professor at Wharton School at the University of Pennsylvania. She has a PhD in economics from University of Wisconsin. Her professional interest range is broad, but she has a focus on public and private pensions, insurance, and risk management. Let me turn the audio over to Olivia Mitchell.
Thanks very much, John. I hope you can hear me all right.
I can.
We have a great session this afternoon. We have 3 speakers, and I'll quickly introduce them. Bruce Meyer is from the University of Chicago Harris School of Public Policy. He studies poverty and inequality, tax policy, government safety net programs such as unemployment insurance, workers' comp, food stamps, Medicaid, and, as we'll hear, the accuracy of household surveys. His PhD is in economics from Northwestern. Eric French will be coming to us from the University of Cambridge, where he's the Montague Burton Professor of Industrial Relations and Labor Economics. His primary research interests are labor, public finance, health, and applied econometrics. And his PhD is from the University of Wisconsin. And then last, but certainly not least, we have Guglielmo Briscese, and I hope I pronounced that correctly. He's a postdoc at the University of Chicago with a PhD from the University of Sydney. And his research focuses on labor markets, behavioral economics, and public policy. And as moderator, I will give you a 1-minute warning. You have 12 minutes total, and we will delay all the Q&A until the end of the presentation. So with that, Bruce, please take it away.
Okay, thank you, Olivia. This is joint work with Aaron Hong, Connor Murphy, Jim Sullivan, and Derek Wu. The opinions expressed are our own, and all results have been through disclosure review. Obtaining an accurate, this is not advancing. Why is that?
Maybe hit escape and restart. There you go.
Okay. Here we go. Obtaining an accurate picture of the economic security of the elderly is a critical issue for both researchers and policymakers. Much of the past work on economic security relies on survey income sources, which are unfortunately prone to income underreporting. About half of private pensions and SNAP receipt is not recorded in surveys, and a substantial share of SSI receipt as well. Recent studies that link administrative data to major census surveys have found that income of the elderly are often much higher than reported in the survey data alone, while the impact of SSA programs is often very different as well. Another approach to examining income measurement through linkage is to examine consumption, as it may be a better indicator of economic well-being than income, as I've argued. We provide the most accurate examination to date of post-tax and in-kind transfer income of the elderly using what we call the Comprehensive Income Data Set, or KID. We link the Consumer Expenditure, or CE survey, to administrative tax records and program data. We are also the first to examine the role of key income sources in reducing consumption poverty for the elderly. Using administrative data on earnings and program receipt combined with the consumption data provides a more accurate picture of the impact of these income categories on consumption. Let me tell you about the data, the survey data and the administrative data. The survey data that we use comes from the CE survey. We are going to use data from the early part of 2015 to 2017. These are survey months for which the reference period for income, the previous calendar year, aligns well with the tax data that we have. For income components with non-response, we're going to use imputed income values as the CE recently started imputing income. We'll link the administrative data from all of our administrative sources that I'm going to tell you about in a minute to the survey using PICs, which you can think of as scrambled Social Security numbers. We're able to link a very large set of administrative data sources. The sources cover earnings, combinations of income sources on tax returns, retirement income, OASDI, SSI, veterans disability benefits, the information to simulate taxes, SNAP benefits, and HUD public and subsidized housing program benefits. All of the administrative data sets, unfortunately, are not easy to use as they are incomplete in terms of coverage or available variables or both. Let me tell you how we construct our combined survey and administrative measures of resources. First, our income concept is post-tax, post-transfer income, the components of which include pre-tax money income, which includes taxable income components and non-taxable components like SSI and TANF. We account for tax liabilities and credits, and we include housing benefits and SNAP, which are in-kind benefits. We create a survey-only version by relying only on survey responses, and then a blended version that combines survey and administrative data. The vast majority of consumer units, what are the equivalent of families in the CE survey, file tax returns. For these CUs, we use AGI reported on 1040s as a starting point, but administrative AGI is net of deductions and may miss some jobs and informal income sources. Therefore, we continue to use survey measures of AGI when it is higher and reflects income plausibly missed in administrative records. We take the administrative records to never be over-reporting, which is, we think, not exactly correct, but a very plausible assumption here. We cannot perfectly align survey income components with the admin AGI concept, so we modify it to get admin AGI, what we call AGI star, to match better. We continue to use survey AGI star when higher, only if survey earnings are non-imputed, and at least one of the following holds. Key administrative data sources are missing for the entire consumer unit, or a CU member is primarily self-employed or works in a high-tip industry. For non-filers in consumer units, we don't have 1040 AGI, so we begin with survey post-tax, post-transfer income as our baseline, and we substitute administrative data for various income components wherever possible to create our blended income. We then use TaxSim to add in tax liabilities, really subtract them and add in credits based on 1040 variables, but those variables don't include tax liability, unfortunately. In constructing consumption, we start with expenditures, but then we make a number of adjustments. We convert vehicle and housing spending to service flows. We impute rental equivalent for those living in subsidized housing, and we exclude spending that is better interpreted as an investment, such as outlays for retirement, including pensions and Social Security. To check our resulting data, we compare the weighted microdata to administrative aggregates. This figure here shows the share of aggregate benchmarks, usually from the national income accounts, that the survey data in our blended income measures capture. You will see that overall, the survey income measures are far below the benchmarks, but our blended income data are much closer to benchmarks. Some components are even slightly above benchmarks, but they are part of a larger income concept, modified AGI, that is still below its benchmark. Other components like OASDI and SSI, for example, are much higher than their survey measures, but still below the benchmarks. To assess the economic security of the older population and see the implications of improving our income measures or using consumption to measure well-being, we calculate the share of individuals in consumer units below the poverty line using 4 income or consumption series, all of which are inflation and equivalent scale adjusted. These resource measures are post-tax money income plus SNAP and housing benefits entirely from the survey data, post-tax money income plus SNAP plus housing benefits that are blended, incorporating administrative data, expenditures, and then consumption, which includes the flow value of owned homes and cars. The poverty line we use is based on the national average supplemental poverty measure thresholds. So here are the poverty rates from our 4 resource measures. Survey-based income poverty, and this is for the period 2014 to 2016. Because of our data requirements, we pool years to get reasonably big samples. The survey-based income poverty rate here is 11.6%, but with blended income, it is less than half that, only 5.5%. And this is for those 65 and older. Expenditure-based income poverty is a higher 13.1%, and consumption poverty is 10.5%. If you've seen other work by Jim Sullivan and myself, the consumption poverty rate tends to be much lower than the income poverty measure, but that's because we've accounted for consumption under reporting and or anchored the rate so income and consumption rates are the same in an earlier base year. We don't do either here. Better income measures and consumption measures tend to show poverty rates for older, lower poverty rates for older Americans. In Meyer and Wu, we see similar large declines from incorporating administrative data in other household surveys. Let me jump and show you what happens to the poverty reduction due to various income sources using our blended data. This figure shows how much poverty would rise in percentage terms if a given income source were removed. We see that relying on blended income and examining consumption both tend to indicate a larger role for many income sources in lifting older individuals above the poverty line. We see a smaller role for OASDI in the blended income measure than the survey income measure, which is a departure from the overall pattern. Last slide, conclusions. This figure shows the reduction, or really the what happens if we remove a blended income component from consumption or income. And it shows that if we were to remove a survey income component, we get a much smaller impact than if we remove a blended income component. We see that with better income measures or consumption, the poverty reducing impact of many transfer programs is larger, and that's very noticeable for housing assistance, SSI, and veterans disability benefits. So in conclusion, our results show the feasibility of improving CE survey income measures and of examining the poverty reduction of transfer programs and other income sources using consumption data. Material well-being tends to be higher measured with blended income and consumption than relying only on survey reported income. Program effects tend to be larger with blended income and consumption than when relying only on survey income data. We're breaking new ground here using new data sets and linking them to a survey that has not been linked to administrative data before. We expect refinements in our future work, but that won't be speedy because of access issues and the disclosure process. Thank you.
Thank you, Bruce. Can you stop sharing, please? And let me now ask Eric French to come on. Good day, Eric. And Bruce, you can mute yourself. Can you share your slides, Eric? There you go. And make them
all right.
full.
Thanks so much for having me and allowing me to tell you about medical spending risk among retirees by race. The previous two sessions have been great segues to this particular talk. So Bruce Meyer talked about bringing together survey data with administrative data. This paper will have a component of that. And then William Doherty talked about differences in financial resources by racial groups. Now, an important driver of financial well-being during retirement, of course, is going to be medical spending risk amongst these older individuals. So just in terms of what we're going to try and do in the context of this paper is dig into the drivers of differences in medical spending by race. So first of all, we'll show you how much does total medical spending vary by race. And by race, we just mean whites versus blacks versus Hispanic-headed households. Second, we'll think about not just total medical spending, but also what share is paid out of pocket and to what extent is Medicare and Medicaid important for understanding racial differences in terms of what is actually paid out of pocket relative to the total. And then finally, we'll show you in a statistical sense what explains these differences where we're thinking about issues such as household composition, differences in health status, education, and the like. Now, just in terms of a key contribution, I think, of this paper is that we've assembled a data set that captures all payers, and this is now in the health and retirement study. Now, the health and retirement study, the basic medical spending component is for out-of-pocket medical spending. So the HRS does a great job of capturing out-of-pocket medical spending, but at least in terms of the survey, that's really all that's captured. What we've done is we've been able to link the HRS survey to administrative Medicare and also Medicaid records, and then to try and capture private payers, veterans benefits, and the like. We've also imputed all the other payers using data from the medical expenditure panel survey. And again, this is going to be household level data that we'll be thinking about. Retirees ages 65 and older in the early 2000s. So let me just jump in and show you some basic facts in terms of how medical spending varies by race. So first of all, just comparing the means, what you'll see is that on average, white households have total medical spending that's modestly higher than for minority households. So for white households, you can see that average medical spending per year is $23,000. So that's $1,100 more than Black households and $1,600 more than Hispanic households. Now, furthermore, if you look at the distribution of medical spending across racial groups, it's actually remarkably similar. So overall, we're going to try and think about what explains these differences, but you can see at some level, there's actually not that much of a difference to explain. Now, where there is a little bit more of a difference to explain is the percentage paid out of pocket. So what you can see here in these red entries is that on average, the share of total medical spending that's paid out of pocket amongst white households is 27.8%, right? So just in terms of what we're doing here is we are getting at, here's the share household by household of all medical spending that's attributable to out-of-pocket relative to Medicare, Medicaid, or other payers. Now, what you can see here is that amongst white households, that share is higher, and it's higher by quite a bit, especially vis-a-vis Hispanic households. Furthermore, what you can see is that the key driver of these differences is actually Medicaid. So Medicaid, of course, is a program for which there's an asset test as well as income and also medical needs test as well. And so this is a program that does seem as though it does redistribute resources from white households to racial minorities. Now, in terms of the next thing that I want to show you a little bit is just to try and understand what potentially drives these differences, at least in a statistical sense. And then we can think a little bit more deeply about what are the deeper economic forces causing these differences. Now, just in terms of what I've shown you already is that white households spend a little bit more in total, and they spend a lot more out of pocket than minorities. Now, just in terms of some of the potential drivers that I want you to think about, first of all, demographics. So again, this is household level data. So white households, they tend to have more old individuals within the household. They're also more likely to be married. So almost mechanically, white households should have more medical spending just because of the number of bodies in the household. And we'll also think about other aspects of these households. Now, in terms of what I'm going to do, it's actually pretty simple. First of all, I'm just going to regress medical spending or the out-of-pocket share on a race indicator. So, of course, the indicator on race is just going to give us that mean difference in medical spending. And then by adding in extra covariates, we'll see if we can explain these differences. So let me show you first for differences in total medical spending by race. And again, total medical spending includes out-of-pocket, Medicare, Medicaid, other payers such as veterans and private insurance payers. So what you can see here, so the $1,100 difference in what we call the base case, that's just the raw difference in mean medical spending per year by race. The full, what that means is that what we're doing is once we control for demographics, a very large number of health indicators, all the health indicators that are basically available in the health retirement study data, education, income, and region, we can fully explain differences in medical spending. Taken at face value, once we control for all these other covariates, Black-headed households on average actually spend $360 more per year than whites. You see the same basic patterns when we're thinking about Hispanic versus white households. Again, Hispanic households spend less in total than whites. However, once we control for all these covariates, they explain more. So just in terms of what's in this column that has these red objects here, these are the shares explained by the different covariates. So we're using what some people might call a Gale-Bach decomposition here. What I really want you to take away from this is that when thinking about total medical spending, demographics and income fully explain all these differences in medical spending. So again, demographics just largely meaning that whites are more likely to be married, and so household medical spending is higher. The second thing, and I think there's actually interesting interpretation issues about this, is that more highly educated households do spend more. there's interesting questions about why more educated households spend more, whether that happens to capture something about their ability to be an advocate for themselves with medical professionals, to what extent it's related to something about they just spend more because they're very patient individuals, they invest more in their health human capital. The interesting issues here, although that's really what I have to say so far. Again, the same objects that drive differences in total medical spending between whites and blacks also drive these differences in medical spending between Hispanics and whites. The only other thing that I'll note is that health, it tends to be worse for both blacks and Hispanics. So of course, if you're in worse health, you tend to consume more medical resources. So because racial minorities tend to be in worse health, we would have expected them to consume a little bit more in the way of medical resources. But again, that's fully offset by demographics and education. Now, interestingly, the covariates that we're using, they cannot fully explain out-of-pocket differences in the out-of-pocket share by race. So just in terms of what the bolded numbers again show is that on average, blacks spend 5.7 percentage points less out of pocket in terms of the total share of medical spending that is out of pocket. Now, if we go to full, what that again means is that once we condition on all these different covariates, demographics, health, education, income, and where people tend to live, we can explain part of these racial differences, but not all of them. Thanks. So just in terms of these key differences, it happens to be health and also income. So this sort of makes sense, given that at the very start, I showed you that Medicaid was important in terms of understanding these out-of-pocket shares. And of course, individuals with relatively low income are going to be more likely to be eligible for the Medicaid program. And again, individuals who are in worse health status, they're more likely to get certain sorts of benefits. And racial minorities tend to have lower income and worse health. So just in conclusion, white households have higher total medical spending on average. This is fully explainable by covariates such as, for example, education. And again, this brings up interesting issues because at some level, we find no direct evidence of racial inequities in spending above and beyond what's explained by education. But of course, this begs the question of where these educational differences come from. Furthermore, we also showed that white households tend to pay a higher share of their medical expenses out of pocket. This is partially, but not fully explained by their higher income, which makes them often less eligible for Medicaid and also their better health. So in this sense, the Medicaid and also to some extent the Medicare programs provide redistribution across racial groups. Thank you.
Thank you very much, Eric, for being on time and so clear. Let us ask you to stop sharing, and I will next ask Guglielmo Briscese, I hope I pronounced it right, to share your screen. Thank you, and you can make it full screen. Go ahead.
Great. Okay, so you can all see my first slide. Assume yes. Okay, so thanks for the invite and congratulations to Eric, Bruce, and the other presenters today. All wonderful and very, very interesting projects. Today, I'm going to talk to you about our ongoing project on improving the take-up and participation into the ABLE savings accounts. This is a joint work with Professors Michael Levere and Professor Harold Pollack. But I also would like to acknowledge all the incredible work done by the Inclusive Economy Lab team at the Harris School of Public Policy, especially Jesse Orr and Patricia Vannissenhoven, who've been helping with this project. Obviously, all the opinions that are expressed in this presentation are our own. So I will explain a little bit better what ABLE accounts are all about in a second, but they are essentially savings program and savings products that offer people with disabilities the opportunity to save money without affecting their federal subsidy, federal benefits that they receive. We have access to a novel set of admin data at the state level in Illinois, and we complemented that with different survey data sources. And the picture that emerges from this preliminary work is that the take-up rate is relatively low, not just in Illinois, but also nationwide. And we've identified 3 key barriers to take up, which is limited knowledge, so low awareness, some administrative barriers, and obviously the financial constraints. And I will talk to you later today also about these ongoing novel seeding pilots that is being made possible thanks to the RDRC generous grant. So ABLE accounts essentially are saving products that people living with a disability and their carers can set up that allows them to eventually gain more financial independence. For SSI recipients, up to $100,000 is exempt from what is actually the $2,000 resource limit. So in other words, if you're an SSI recipient in the US, you cannot accumulate more than $2,000 in assets. And that is because it's a policy that was last raised and last implemented in 1989 and has not been updated since then. Luckily, over the past 4 or 5 years, this new program emerged as a result of like 10 years of advocacy and lobbying work called ABLE, that is now offered across 46 states, that allows these individuals to put money aside, and then eventually they can withdraw or spend this money directly on eligible expenses without getting taxed. And they also can accrue interest by choosing different investment plans on these ABLE accounts. These plans are usually administered and promoted at the state level. In Illinois, the program is administered and promoted by the Illinois State Treasurer's Office, who also happens to be our key partner in this project. So despite the many advantages of this program, we sort of realized that there is a relatively low take-up rate, and we try to look at the reasons why that is the case. To unpack the different barriers to take up, we leveraged 3 main data sources. This novel admin data set from the Treasurer's Office in Illinois that includes 5,164 account beneficiaries between 2017 and early 2023. We complement that with data from 2 different surveys. One is a survey that we co-designed with the Treasurer's Office that implemented last year on 2,515 ABLE eligible respondents in Illinois and Wisconsin. And then the other survey that is part of the seeding pilot that we have implemented, where we ask individuals to receive the seeding money, as I'll explain in a second, to also answer a few questions. So the very first striking result that we realized and observed from the admin data analysis is that the take-up rate is not just relatively low compared to the SSI eligible population that could actually take up this program in Illinois, but it is also not taken up homogeneously across the state. If we map take-up rates on the zip codes of Illinois, what we see is that the large majority of accounts are actually concentrated in wealthier areas. In other words, higher income households are just much more likely to take up the program and own an account. Obviously, this, because of the particular circumstances of Illinois and the city of Chicago, this also tends to be correlated with race and also education. This is supported by survey evidence. We have data from this other survey that we implemented last year that confirms the income disparities in take-up rates. In other words, wealthier households are more than 3-4 times more likely to own an account compared to lower income households. Part of the barrier to take up that we've identified is the program awareness. Some individuals are just not even aware that the program exists. And what we did find in this survey is that program awareness is significantly and substantially higher among wealthier and better connected households. The interesting thing is that it's not just income per se, but income might be more of a proxy of a broader set of variables that explain why higher income families are more likely to know about this program. And one of these mechanisms that we unpacked in this survey data is that higher income households tend to be just more connected with several disability services organizations. There's a lot of organizations, NGOs, and not-for-profits in the state that offer services and assistance in the disability space, and higher income families are just much more likely to be connected to those organizations or to actually be members of that organizations. Interestingly, also from the sign-up survey of our seating initiative, we did find that 35% of the individuals that we're now currently helping to set up an ABLE account actually learned about the program from the recruitment email of that pilot itself. The other barrier that we've identified is a set of admin burden. In the behavioral science literature, this is usually a term that includes a broad set of actual complexities in the sign-up process, maybe sometimes complexities with the IT system or the compliance framework of a program, or some other times also includes the perceived psychological cost of signing up. And that includes also some misconceptions about the program. And we did find that that is the case also for ABLE, as it is often the case for many other government-provided programs and services. Across our 2 surveys, we actually found that only 3% of respondents correctly identified all the program features. And that is a statistic that is not that much higher when we include people who also already own an account. And so that is quite problematic in of itself. The other barrier that we identified is that low-income households are also concerned about not being able to save enough money into disabled accounts if they were to open one. Strikingly, we find that there is almost an identical share of individuals in the low-income households beings between the 2 surveys that report having that concern of not being able to save enough money as a reason for not opening an ABLE account. However, despite these barriers, what we did find from the survey is that the program, especially once the features of the program are explained to survey respondents, the program is very attractive to the large majority of people across all income groups. More than 70% of our participants actually said that they will be interested in opening an account, and they find that the program is attractive. So lastly, what we have been doing since about June this year, we launched an effort, thanks to the IDRC support, to enroll and seed 400 new Illinois ABLE accounts. And what we do, we work with organizations that are active in the disability policy space in Illinois. So far, we have partnered with the Arc of Illinois, Easter Seals, Progress Seal, and Chicago Parks District to reach out to their members and individuals that might be receiving the mailing list, to notify them about the existence of the ABLE program, and also to invite them to take up this financial incentive that we're offering, which consists in $100 that gets deposited directly in their account upon completion of our sign-up survey and completion of the creation of the account, the sign-up of an account. The purpose of this $100 upfront seeding incentive is that ideally what we hope it does is it offsets all the perceived admin burden cost. In other words, it would make the sign-up process, or the pain of going through the sign-up process, worthwhile. So far as up to last week, we have received about 147 complete survey responses from these eligible participants. We are now in the process of matching that survey data with the Illinois State Treasurer's Office admin data to see how many of these individuals ended up opening an account, receiving the seeding $100 account financial incentive. And what we do see from the survey data is that the individuals who are taking part at least in our survey, they plan to save at least $1,000 or more per year in these accounts. So the next step, this is my last slide. So the next step is to complete the seeding pilot. And we also plan to then, as I said, merge survey and admin data to track participants' contributions and withdrawals over the next 6 months to know how they're using these accounts and if they keep them open, how they engage with it. And then early next year, we will also implement a follow-up survey to better understand their experiences. Ultimately, the purpose is to understand exactly what are different mechanisms that play a role in these barriers that prevent greater take-up rate, and inform policymakers on effective strategies to overcome each of these barriers. And ultimately, the goal is really to improve participation into this program so that we can improve the financial well-being and self-sufficiency of Americans living with a disability and their carers, and in the long run, hopefully improve also their employment opportunities and earnings.